And I think it comes down to we do not value women's lives beyond their reproductive capacity. If you're done with having babies, well, then
what difference does it make?
What difference does it make?
My guest today is Dr. Corinne Menn. She's a board-certified OB-GYN, a certified menopause practitioner, and a colleague of mine at Alloy Health. Dr. Menn specializes in menopause care and particularly in developing thoughtful, evidence-based approaches to hormone therapy for women with a history of breast cancer. And this is one of our most commonly asked questions, the link between hormone therapy and breast cancer. But she also brings something really critically important to this conversation, lived experience. Dr. Menn is a breast cancer survivor. She was diagnosed at only 28 years old. And for decades, we know that women have been told that breast cancer and hormone therapy are not compatible, even when they're suffering with severe menopausal symptoms that affect sleep, mental health, relationships, and sexuality. So today's conversation is about moving beyond the fear and dogma and looking carefully at the evidence and asking whether there's room for nuance, shared decision-making, and compassion in how we care for breast cancer survivors navigating menopause. Welcome to The Second Opinion, Dr. Menn.
Oh, thank you so much for having me. I'm honored. And second opinion is exactly what I deal with every day with my patients who, have turned to so many places to try to get help with, navigating their complex menopause and, have met with like barriers and not even a discussion of options.
Right. And I think that's a very important point to make is that, there's the data. And then there is the lack of data, which is where opinions come in about how do we address issues with women who have had breast cancer or even are at risk for breast cancer. And this is where I want to center and start this conversation. So let's start with the basics. And I think for decades now, estrogen has gotten a serious black eye and has been blamed for causing breast cancer. And how did estrogen become the villain of the breast cancer story?
Oh, how did it become the villain? Well, I'm sure you've covered this many times in many places, but, unfortunately, the Women's Health Initiative, which I always remind patients who come to me asking me about it, is we never want to throw the baby out with the bathwater. We learned so many incredible things from the Women's Health Initiative. It's a landmark and a really important study, but it's also a lesson in actually interpreting data and messaging data and nuance and actually not believing the very first headline that you see. And so, unfortunately, back in the early 2000s, the WHI data, the WHO was, stopped abruptly, prematurely, and a message was sent out that estrogen is bad, it causes breast cancer, it causes heart disease, everyone should get off of it. And now we know, and actually, if anybody read the paper back then, which you did and you knew, that's not true.
Right.
And that the estrogen-only arm showed a decreased risk of not only getting breast cancer, but of dying of breast cancer. And subsequent observational studies and other studies have shown that that extends to estradiol and not just conjugated equine estrogen, but we have the best data on that. And that progesterone is not the same as progestins, and that progestins perhaps had a small associated increased risk. And so that's just left a generation of doctors afraid. And the word breast cancer is the biggest barrier to even the average woman getting help with their menopause. And you and I know we see that the thousands of patients we've helped at Alloy, a lot of times it's that family history of breast cancer that has prevented them from even having an option of hormone therapy. And so God forbid, if you've had breast cancer, no one wants to talk to you about it. They don't even want to talk to you about local vaginal estrogen, which we can get into. And the other thing is that breast cancer is not one disease, and we can talk about that we've got to look at it as different types of diseases and different types of patients. It's not black and white. And so women deserve a lot more than that than what they're getting.
I think it's safe to say that the quality of the data that we've had really about breast cancer and estrogen therapy prior to the Women's Health Initiative, which changed everything, was really not great because we had never had, a randomized controlled study that actually looked at a group of women, some given estrogen, some not, to be able to draw that conclusion. But even before the WHI, there was a slight increase in the risk of breast cancer in estrogen users. And let me explain to you, to our listeners, why that may be the case. Anytime you do just an observational study and you're saying, oh, let's look at women who are diagnosed with breast cancer, and then look back and see how many of them took estrogen therapy, how many of them didn't. Well, there's a certain bias in that because the women who are on estrogen therapy or a hormone replacement therapy are going to be monitored more closely. So you're going to see more cases of breast cancer just by merit of the fact that these are women that are more likely to get mammograms and be diagnosed earlier. So there's a bit of bias that was there. And the whole point of the Women's Health Initiative was never to answer that question of whether or not it caused breast cancer or not. It was really looking at heart disease. So that was sort of a byproduct that really took us down a road that's taken us now, 24 years now of trying to unpack this data?
Yeah, and it's so interesting. When I look back, I don't remember the WHI. I know lots of doctors, or when it came out, and it took me a while to be like, how come I don't remember that announcement? And then it dawned on me in the summer of 2002, when, everybody was freaking out. I was on, I think, my 5th round of chemotherapy, and I was in my program director's office asking to have a leave of absence briefly. I had tried to push through months of chemotherapy while being an OB-GYN second-year resident, but I just couldn't handle it anymore. And looking back, it wasn't the chemo. It was the abrupt premature menopause that the chemotherapy had temporarily put me in, and I had no help. I did not know that my new onset of insomnia, anxiety, of course, hot flashes, all the other symptoms were, I was really chalking it up to you're just really down and exhausted from your chemo, which I was. But honestly, looking back, I now know it was the abrupt hormone withdrawal. So I was in a fog. I don't remember the WHI announcement.
Well, that's certainly understandable that you had other things on your mind other than, let me go get the latest journal on hormone replacement.
Well, clearly no one was, but then as a second-year resident, there was I don't remember one single lecture on HRT or anything. There was just no interest. And if they were planning on doing it, well, clearly come that June or July, it was just not on the table anymore.
I had practiced for 10 years before that study came out. And so our conversation about hormone replacement therapy was not really focused on the breast cancer part of it at all. It was focused on, we have this now long-term data that says that women who are on hormone replacement therapy have a decreased risk of heart disease. And this was really the conversation, even if we were willing to accept a slight increase in the risk of breast cancer, it was more than worth it for all the lives we were going to save from heart disease, because that's the number one cause of death for women. But let's get back to you, because that has got to be devastating. You're 28 years old. You are a resident, and you're diagnosed with breast cancer. Tell me, how did you even figure out that you had breast cancer, and then what happened subsequently?
Yeah, I think it's a classic story of women being dismissed. And, backing up a little bit, so I was diagnosed December of 2001. So in September of 2001, I'll always remember September 2001, September 11th, and it was right around that time that I felt a lump in my breast. And it was right around the time that I learned that my mom had been diagnosed with stage 4 ovarian cancer. And she was only 54 years old, quite young, really, still, for ovarian cancer. shocking to me. And she had dismissed the symptoms herself as she thought it was a fibroid, and she kind of ignored it. And honestly, looking back, I actually think she knew something was really wrong. And I think she was afraid for a variety of reasons, her life circumstances, what was happening in her life in other ways. I think she didn't want to have to now deal with a serious medical thing or burden her children. And so I think she let it go. So again, dismissing ourselves, right, as women. And so then I felt my breast lump. And again, this is 2001. I don't think people were really aware of the BRCA mutation or the family history or even young women getting breast cancer. So I had a number of my fellow female attendings and fellow co-residents. I'm like, oh, just feel this in my breast. Like, what do you think this is? I'm like, should I be worried? And they're like, oh my God, no, Corinne, you're like only 28 years old. It's probably a cyst. Just follow it for a few menstrual cycles. And I did. And I was just too busy being a resident, frankly, to get in to see my GYN. And I'm just like, whatever. I'm like, I'll just see it. It didn't really bother me. It was small. It was mobile. And I was like, okay. Fast forward 2 months later, I was on the labor and delivery floor, doing call, and my husband shows up on L&D and is like, I got to tell you something. And he pulls me aside and tells me my mom, suddenly died. We were trying to get her to come back to New York to try to get some more care, and things just, spiraled. And so I was shocked. So again, I put off, dealing with my breast lump. And the day of her funeral, I remember coming home and I said, you know what? I just buried my mom. She was only 54 and she had ovarian cancer. That's weird. And I've got a lump in my breast. I'm like, Corinne, maybe you should check that out. And so I waited a couple more weeks and I finally got in for a biopsy. And looking back, I wasn't even scared. And then, like a day or two later, after I had the ultrasound and biopsy, I was in the middle of prenatal clinic. And this is another lesson I learned, is how not to tell people information. And the radiology resident paged me and I, answered it while my patient was there in the exam room with me, and she was pregnant and she did not speak English. And I just, heard the news, sorry, Corinne, it's breast cancer. And I just, threw the phone across the room. I threw my pager. The very first thought in my mind was, I'm never going to be a mom. That was the very first thing, because all my fellow residents were either trying to get pregnant, they were pregnant, they had just had a baby, and we were OBs, we were delivering babies, and I was about a year married. So that was on my mind. And I thought, oh my God, I'm never going to get to be a mom. And hence began my journey. And so I tell you all that because I think it encompasses my mother dismissing herself, me dismissing myself, my own fellow doctors, and I don't blame them, but dismissing me as you're too young for breast cancer. And then, it kicked off an experience where I had, wonderful medical care, but along the way, I just continued to be ignored and dismissed in all of the other ways that breast cancer was impacting me, which we can certainly get into.
Yeah. I mean, so at 28 years old, you're newlywed and you're about to, go through, everything you have to go through for breast cancer and chemotherapy. Yeah. And did at any point, did anyone say, hey, Corinne, I know this is difficult, but let me sort of prepare you for what's coming? Because you're going to be plunged into menopause pretty quickly, overnight from the chemo. Not a mention?
No. I mean, I am very grateful. I was in the New York City area. And so at the time, once they knew that after my surgery, that they knew I was going to need chemo, because I had one positive lymph node, I was lucky to get sent for fertility preservation, which again, in 2001 was not always standard of care still, but there was observational data that suggested that doing some fertility treatments prior to chemo did not seem to, worsen the prognosis or recurrence risk. And there was emerging data that suggested that even at some point in the future, once you were done with treatment, that pregnancy itself did not worsen your prognosis. So they're like, I was married. They said, okay, we can, because at the time it was very actually hard to freeze eggs, but they could freeze embryos. So we froze some embryos. And so the whole focus about chemo destroying ovarian function was on fertility. There was really no conversation on what that early, either temporary or permanent menopause was going to do to the rest of my body in terms of my symptoms, my mental health, my sexual health, my long-term health. None of that, like none of it. And, I look back kind of embarrassed, like I'm an OB-GYN, you think I should know, but, I was only a second-year resident. And frankly, those issues were not well addressed in my residency.
You were fortunate that was 2001 because the conversation in the late 70s, early 80s was quite different. There was a time, and certainly when I was practicing, where young women who were diagnosed with breast cancer were told, absolutely, you could never get pregnant.
Yeah.
Because, all that estrogen is going to flood the system and it increases your risk of recurrence of your breast cancer. And what we have to now acknowledge is the fact that was not based on data. That was pure conjecture because you had said, oh, well, estrogen and breast cancer, so clearly there must be a link. And I know for a fact that there were many women who were diagnosed in my practice who had breast cancer, desperately wanted to be mothers.
Yeah.
And they conceived on tamoxifen. So these are young women who have already, and they were also not really counseled, and I know this because I saw this, on the fact that just because you had chemotherapy, you may be in menopause temporarily, but the younger you are, the more likely your cycles are to return. And so these women not only had the trauma of breast cancer, chemotherapy, and then being on a medication, tamoxifen, which is an estrogen blocker, sort of for lack of a better term, we'll call it that. And they did not realize that, it kind of blocks it, but not really. And these women, imagine after all this, and then you're on tamoxifen and you get pregnant.
Well, it's so interesting. And it's funny that you brought it up because I just wrote a Substack yesterday about the mysteries and the paradoxes of tamoxifen, and that a lot of women don't actually understand how it works. And in fact, tamoxifen, increases your estradiol levels by 2 to 3 times in premenopausal women. 80% of women will have functional ovarian cysts. They absolutely can get pregnant. And here's a fun fact. Before I started chemo, I harvested my eggs and did, fertility preservation using a tamoxifen protocol. So it was at the time at the Dr. Octay. He's kind of very famous in the fertility preservation world in cancer patients. He was at Cornell at the time, and they had a new protocol in young breast cancer survivors, and they would give them higher doses of tamoxifen as a means to stimulate ovarian, ovulation and harvest the eggs. But at the same time, the tamoxifen is blocking estrogen receptors in breast tissue and other places. It doesn't work quite as well as other, ways to get those eggs. But, I use tamoxifen so it always surprises people when they hear that. But, many women are told you're going to take an estrogen blocker, like tamoxifen, which is an important medication. I took it for 10 years. But they're not really explained what it does. And I think when you call something an estrogen blocker, it adds to this idea that estrogen is bad. Right?
Exactly.
And I think, if we explain to patients how tamoxifen works, it's an important drug. And a lot of women refuse to take it out of a lot of fear, or no one helps them with side effects. But for instance, because they're taking an estrogen blocker, these women think, well, I could never even use vaginal estrogen because why would I want something? Why would you give me estrogen when I'm on an estrogen blocker? Or tamoxifen is putting me into menopause. Well, actually, no, it doesn't put you into menopause. So there's a lot of misunderstanding about that.
I think that a little bit of humility is in order because there's so many things that we don't understand about how breast cancer behaves. But I think it's safe to say, and I'll ask you if you agree with me on this, is that the consensus now is that estrogen does not cause breast cancer. Is that a fair statement?
I agree. And I think what we have to think about is estrogen is an important hormone in a woman's body, and it impacts breast changes throughout a woman's life, from puberty, breast bud development, breast development. And then we have to understand estrogen's an important part of, obviously, when you're pregnant and breastfeeding, and all of these things change breast tissue. So, we've learned this from ovarian cancer, right? We know that multiple ovulations, right? Every time you ovulate and have a cycle, there's, cells are dividing. There's more chance that along the way, a cell can become malignant, right? That can happen in every part of your body. Mm-hmm. When you are having menstrual cycles every month, right, for years and years and years, there are changes in your breast from that growth and that cyclic change. It's actually really interesting when you read about what is happening during a pregnancy. We get a maturation of our the breast ducts and glands, and there's cellular changes that might be actually quite protective. And mm-hmm. Yes, so interesting. And that goes along with an environment of high estrogen. And it's also probably why when women breastfeed for a long period of time, the cells and the tissue in your breast is different than when you are, having regular menstrual cycles, right? And so it's not about hormones are bad, hormones are good. Hormones impact cell structure, cell growth in all sorts of ways, and how that interacts with your own genes, with environmental factors, with diet, with stress, with inflammation. And so I just say that not because I'm telling people what causes breast cancer, but I think people need to understand it's a lot more than estrogen is bad, right?
Exactly.
And especially as we see an increase in breast cancer rates go up in our country and in the world, the worst is in younger women. We see a higher rate of new breast cancers. I think we have to think a little bit more broadly about that this is multifactorial and that we are living in a different environment than we lived, many years ago. And you and I both know that hormone therapy rates have gone way down. And even with the new movement of menopause and more women having access to evidence-based HRT, the rates are still extremely low. So that is certainly not responsible for the increased risks of breast cancer. And young women don't use HRT. Women in their 20s and the 30s who are most at risk for this increased rates of breast cancer, they're not on HRT. They're just living their lives in their normal reproductive years. So yeah, I think we need humility. Avram Blooming has talked about this a lot. Like, anybody who says they know what is the cause of breast cancer is not being humble. We don't know. What we do know is that our treatments have evolved. Women are living longer. They are being diagnosed younger at an earlier stage with a better prognosis in all types of breast cancer. Mortality is way down. And so that brings us back to where we started, is that we cannot ignore this growing army worldwide of women living longer, cured or very, very stable, living years without a recurrence, but left with the devastating side effects of long-term estrogen deprivation, premature menopause, regardless of whether they're ER positive, estrogen receptor positive, or ER negative. And we're just ignoring that. And we can't anymore. It's just not acceptable for so many reasons, but primarily because of suffering and the long-term risks on these women's, chronic disease risk and preventative health, concerns.
Right, because we cannot ignore the fact that for women who have early or premature menopause, either temporarily and then subsequently, they will be in menopause earlier, because there are some women that will have their ovaries removed if you are a genetic carrier of BRCA1 or 2, which are the breast cancer genes that we know of. And those women have their ovaries out. We know that puts them at risk for increased risk of cardiovascular disease, for Alzheimer's, for osteoporosis, all of these things which are important for longevity. But the thing that I think gets the shortest shrift in this conversation is quality of life.
Yeah, quality of life and choice. And, I think, there's two things that are, kind of really on these opposing sides that we are not really addressing. And, one is that we have very clear guidelines on how we treat premature ovarian insufficiency or premature menopause in the average situation, not with cancer involved, right? And we know it's standard of care that you need full HRT up until the age of at least natural menopause if you are plunged into premature menopause. Why? Because of everything that you just said, that, you can't just castrate women or, have them be plunged into some sort of, menopause without addressing it, right? So why do all of those concerns go completely out the door when a woman has breast cancer? And I acknowledge that we need to sometimes treat these women with estrogen deprivation, but we still can't ignore what's happening, right? And pretend it's not happening. So that's number one. That just doesn't make sense. And whether you give them systemic estrogen or not, you better damn well come up with a plan on how you're going to help manage all of the collateral damage. And the other thing gets back to the pregnancy thing. It's now become widely accepted, obviously, fertility preservation, and it is also widely accepted that breast cancer survivors, regardless of their estrogen receptor status, at some point in time can pause their treatment, or if they're done with treatment, consider pregnancy. And that the data, even we've had a very important randomized, or it wasn't randomized, but it was a controlled trial where women chose to pause their tamoxifen or aromatase inhibitors after being on it for 2 years to get pregnant. And the results show that there doesn't appear to be an increased risk of any prognosis, right? But so what I say is, why do we allow shared decision-making, patient values, and choice when it comes to her becoming a mother? But if pregnancy is not on the table, well, then we won't even talk to you about vaginal estrogen or a low dose of hormone therapy if your quality of life is poor and you are a big girl and wanted to use it for whatever reason. And I think it comes down to, we do not value women's lives beyond their reproductive capacity. If you're done with having babies, well, then
what difference does it make?
What difference does it make? Right. And why would you risk any recurrence for quality of life? I'm like, well, you're allowing me to risk recurrence, supposedly, or, back, many years ago, to have a baby. And we still don't have perfect data on pregnancy after breast cancer, but we've got, it's certainly reassuring, but we give choice there as long as it's for having a baby.
Right. And I think that we're asked to make decisions with very much imperfect data and incomplete data about this. But I don't think that that's the way it's ever presented to patients. Like, look, hey, I don't know. This is what we have. This is where an opinion is important. This is where, as you said, shared decision-making comes in helping patients sort of navigate what is life like after breast cancer. And, length of life is not the only metric that we should use when evaluating. You should be happy. You're alive. Oh, what more do you want? Sex? Happiness? A brain? We're kind of leaving those out of the discussion, which is unfortunate.
Absolutely. And ignoring, we've learned a lot about breast cancer. It is not one disease. It's heterogeneous. I tell my patients, your breast cancer is as unique as your fingerprint. You cannot compare yourself to anybody else. And of course, we've got categories: estrogen receptor positive, estrogen receptor negative. There's other markers. There's different types and different stages, et cetera. And so we need to look at that person's breast cancer, how that cancer behaves, what's her recurrence risk, how far out is she? There's a lot of ways that we can do that now, because we know how individual it is.
So let's talk about how the Menopause Society now has changed their language in their recommendations about women after a diagnosis of breast cancer.
I'm really happy to see this past summer, the Menopause Society issued a practice pearl. Dr. Holly Peterson, who's actually become a friend and mentor of mine, and she's a breast specialist, and she runs a high risk for BRCA carriers clinic, and she went through all the literature and basically outlined everything I just said and emphasized that we have a black hole of menopause care for these women. We have conflicting data. We have a lot of data that's pointing to there may be no increased risk. And she, the practice pearl really outlines how important it is to individualize. And so that practice pearl, I thought, was very, very important because it gives the general member, at least a landing page to say like, okay, I'm not crazy for having this conversation, right? And subsequently, since then, there's been a couple of editorials and a couple of review articles. One that just got published actually this month. The lead author was Sarah Glynn. Dr. Jim Simon was part of it as well, and a whole team of other people, which basically did exactly what you and I are talking about, is basically lay out all the different scenarios, all the different types of hormones, from local vaginal to testosterone to estrogen to progesterone, and basically review the data. And it was actually, they did a very nice job. Again, it's not a new randomized controlled study, but it's another framework. So I feel like it gives us menopause specialists out there who are willing to work with patients and treat them with shared decision-making, dignity, giving them informed consent and a full range of options. It makes me feel happy that we're not out there on our own, and that we have other doctors and, the medical society who are there to support that this is real. It's not crazy for us to talk about this.
As you said before, breast cancer is multifactorial. There are many things that go into that. It's not going to be just a gene on or off. It is all of the lifestyle things that we talk about. And one thing I want to ask, before we get to, and we're going to do a lightning round because I love this, but why do you think that, given everything that we know that is readily accessible in 2026, why do you think that there's so much resistance in the medical community to involving women in these decisions about their lives and their treatment?
I think it's about a few things. I think that listen, doctors don't go into medicine to be jerks to women, right? I think most doctors want to help patients, but I think we go into it with so much bias about women's suffering, and that, we don't value or listen to their pain, their concerns, particularly when it comes to things like quality of life in menopause or sex, et cetera. So that's like one thing, I think. And I think that the medical legal world has huge impacts on how we practice medicine. And when you say the word breast cancer and you say the word hormones, a doctor who is just not up to date on these things, it's not in their wheelhouse, their knee-jerk reaction, and I get it, is to protect themselves, to protect their medical license. There's so much fear. I also think that the vertical integration and the corporatization of menopause has created little factories, frankly, where doctors are just cogs in this factory. They don't have much time to sit down, really understand what that woman's going through. So I really believe doctors have good intentions, and if they were given the right environment, they'd be able to better serve patients, because we have evolved where we're talking more about our own inherent biases and how we approach patients. But we frankly now don't even have time when we're seeing these patients to allow us to explore those things. So I think it's a humongous problem, and it's not just breast cancer, right? It's women who are dealing with all sorts of medical things. And one thing I just want to clarify for anybody listening to this, because this is really important to me, is that I don't want women to think if they don't have a family history of breast cancer that they're not at risk. Most people actually don't have a family history, and even if you do, most patients are not going to be, maybe 5 or 10%. We might find that there's a genetic reason.
So I want to get to the lightning round right quick, and some of these we may have already covered, but one of which is the use of hormone therapy after DCIS. And DCIS means ductal carcinoma in situ, which is basically stage 0 breast cancer. It hasn't invaded, it hasn't gone anywhere. And the overwhelming majority of women with DCIS are cured after their surgery. So for these women, some of whom are young, what can those women, or can those women take hormone therapy after this diagnosis, should they choose?
Yes, I think that this is one of the easier situations. They still face barriers, but yes, they can. And I think it depends on a few things. Some of these women they don't have to have bilateral mastectomies. Some of them choose to because of, say, a family history, or they just are like, I don't want to do screening. That's their choice. Those cases, that's easy. Some DCIS is diagnosed in women who are still premenopausal. And if they've only had a lumpectomy, these women are offered tamoxifen and radiation, but it's not to cure the DCIS. It's to prevent an invasive, a new invasive disease or getting a new primary breast cancer. And then we've got, women who are diagnosed with it when they were menopausal. But in all of those scenarios, hormone therapy is not off the table. And I just want to, anybody listening to this, this is where I think we are making progress in research. There's a medication called Duavie, which is conjugated equine estrogen, and it's paired with a medicine that's kind of like tamoxifen called basodoxifene. And recent study shows women who were taking that HRT, who were diagnosed with DCIS, their DCIS didn't grow and all the markers of growth were cut in half. Mm-hmm. So when someone says, no, you could never consider it, I would say, talk to me about Duavie. And it is definitely one of the scenarios where I think it's much easier to offer it.
Yeah. And see, this is where I take a slightly different take on that, because if I say someone has DCIS, which is stage 0, non-invasive cancer, you've been treated for it. Offering someone to say, oh, well, let's do this aggressive thing, radiation and therapy and adjuvant therapy, or like tamoxifen afterwards, is like saying, well, no, it has nothing to do with your DCIS. We're trying to prevent a new cancer. That's just like walking up to a woman and say, why don't we take both your breasts off so you won't get breast cancer? That to me is a little aggressive, but that's my opinion.
No, but you make an excellent point, because we are moving towards this. Actually, just this past year, there's more and more talk about who can we observe with DCIS, and and also women should have that choice. Everyone has different levels of risk, and so the general number is that there's like a 30% risk in the next 10 years if you don't take your tamoxifen or you don't do a lumpectomy. If you have a DCIS, 30% risk of having an invasive cancer at some point. But you could monitor and you could screen, and women need choice. And in fact, I will make the argument that I think there's emerging data that suggests that these women, particularly on maybe estrogen alone and now on Duavie, may actually have a lower risk of a recurrence. And so I think we need to be curious and we need to dig a little deeper in those cases.
I agree. All breast cancer is not the same.
Yes.
And how you treat stage 0 is not the same as you treat stage 3
and
or 4.
Our triple negative patients, it's another area that's actually a little easier. So if anybody's listening, we know that triple negative breast cancer, we don't use estrogen manipulation or lowering the levels to treat their cancer. And we know they're most likely to recur in the first 4 to 5 years. Yeah. So when those women are out of that window, many of them, might want to consider hormone therapy. And I am seeing that there's more of an appetite and more of an interest in terms of in the oncology world to have more shared decision making with those women. So I think those women are a bit, quote unquote, easier category. And then people like me, again, who are ER positive, it's a risk benefit analysis, and should not be just an absolute no.
We understand that breast cancer is a multifactorial disease. But if you had to say, what is the biggest risk factor for a woman for developing breast cancer in her lifetime?
Getting older.
Yay, it's correct. That is age. It is not your family. It is just living long enough to get it.
Yeah. And so I think the 1 in 8 number is really misleading. Mm-hmm. It's true. If you get yourself to live over the age of 80, which I hope we all do, 1 in 8 of us might develop a breast cancer, meaning DCIS or something along the way, right? But the numbers are much different for a 30-year-old. Off the top of my head, someone in their 50s, I don't know, it's something like 1 in 50-something women. It's not 1 in 8. But really interesting, Sharon. You know what 1 in 8 number actually people should be concerned about? 1 in 8 women will lose their ovarian function prior to the age of natural menopause. Now that's going to happen before they're 51. 1 in 8. That's millions of women. So I care about the 1 in 8 who are going to get breast cancer. I care, obviously I'm a breast cancer survivor, but I also care about the other 1 in 8s out there and that they're suffering with all these other things. So I think we just need common sense and balance here.
That is fantastic. And I want everybody to take that message. living long enough is a good thing, that maybe, you got to survive all the other stuff to get to even close to a 1 in 8 figure.
Yes.
Dr. Menn, I want to thank you because not only for what you do in terms of educating women about breast cancer and what their options are after a diagnosis, but also just for bringing your personal story forward, because I think that this is something that's not just theoretical for you. And I think that you and I both know that, everybody wants to be a good doctor. However, our personal experiences greatly influence how we talk to patients and how we treat them.
Well, I've learned so much from you, so thank you so much for having me.
It was a pleasure talking to you. Before we close, here are my doctor's orders. Number 1, there are very few absolutes in menopause treatment care after breast cancer diagnosis. What you choose depends on the type of cancer, your family history, genetic status, time since diagnosis, and the individual. And blanket rules do more harm than good. Number 2, vaginal estrogen is safe and appropriate for the majority of breast cancer survivors. It not only prevents and treats the symptoms such as vaginal dryness and painful sex, but it prevents urinary tract infections. Number 3, quality of life matters, and women must be active partners in the decision-making process. Surviving breast cancer should not mean years of accepting untreated suffering. Care should be collaborative, transparent, and grounded in informed decision-making. Join me each week on YouTube or wherever you find your podcasts as I break down topics on menopause and aging. If you enjoyed the show, follow us so you never miss an episode. If you like what you hear, leave a review. You can submit your questions at drsharonmalone.com and click on The Second Opinion. Until next week, take care.